What are the unique obstacles towards reaching some kind of consensus on Medicaid in the environment you've just described with the current issues on the table?
In terms of states themselves working
Well,
together,
the states
or
at
with
the
the
table with the
administration?
federal government.
Well, I think where states come from is that they want more flexibility really around the program. They want to actually be able to set the benefit package, not have the federal government essentially set it. They like more control over the eligibility of people, more control over the pharmacy and so on. So what you find is that the federal government wants a relatively robust benefit package. And a lot of times the Medicaid benefit package is more robust than you see in the private sector. Now, there is a problem in terms of getting physicians to essentially do the care and so on. The other huge problem in Medicaid is the so-called dual-eligible population. These are people who are eligible for both Medicare and Medicaid. Which represents about 60% of the cost of the Medicaid program. That's an awful situation. People don't know where to go if there's a problem because you've got two levels of government into it. So I think that's something that overlapping jurisdiction should be eliminated over a period of time. Plus the other area is huge is long-term care. We have no real long-term care policy in this country, and therefore more and more the elderly are ending up in nursing homes and are part of Medicaid. So that's going to continue to grow very, very rapidly. So it's an area where the federal government, I think, has to take over more responsibility.
Well, that leads me to my next question, which is if you could give me a sense of priorities that the Governors Association has, particularly when we look to 2009 and a new administration, whoever the president may be, but what are the sense of priorities about these healthcare issues and what the governors would like to see done at the federal level?
Well, the first two would be developing a good long-term care policy. That's probably going to require a new revenue source, unfortunately. But it seems to me that you need a continuum, that once people become 65 and end up in a program, they should not, at some later level when they're 75 and run out of money, end up in partly a state program and partly a federal program. So I would say cleaning up that so that once people enter Medicare throughout the rest of their lives, they're in one particular program. So that dual eligible problem is huge. The others are, I would say, a lot around the flexibility, really, of running the rest of the Medicaid program. And then if, in fact, we're into broader healthcare reform, then I think it's a matter of who runs the program and how much flexibility do you have around it. States have experimented a lot, have done a lot over the last 10 years. They have a lot of expertise now to bring to the table. I'm assuming that it's going to be a state-run program if it's, in fact, more of a comprehensive program, that they will not follow a federal Medicare approach, that it will be state-administered. If that's true, then I think states would want a lot of flexibility on how they set up their alliances in terms of matching providers to new people coming onto the rolls, so that they're able to tailor the programs more closely to the needs of their citizens.
You have been in Washington for a while. You've heard the healthcare debate more than once. We're in the middle of a presidential campaign now. What is your take on how serious a debate it is in terms of it leading to some action?
Well, it's interesting. You know, the last time before President Clinton came in, there was a lot of experimentation in the states. And it all stopped as the pendulum swung to Washington. And of course, they failed to do it in Washington. I would say from the state perspective, there's not a lot of people who believe that Washington, D.C. is going to really get it done this time. And I think our view is that they probably should do it incrementally rather than try and do one big domestic sweeping program. And really what the federal government needs to do is to set the foundation so that the states can move. And the foundation, I think, is what are the electronic healthcare records, what are the requirements there, what are the standards in quality, what are the standards, are we going to have price transparency? But to set that foundation forward and perhaps provide states with some funding for other low-income programs and let the states move forward and try to implement it.
Why is there not a lot of hope among the governors that Washington will move?
Well, I'll be honest with you that Washington has become quite partisan lately, and that you've really got to have more than a 51-49 vote in the Senate. You've really got to have a very strong consensus to move it. And the two parties seem to be very, very far apart on health care. The other thing, of course, is that the deficit is getting dramatically larger. And I would think that the next time CBO does an update because of the slowdown in the economy, that the deficit will probably be up by $100 billion or so, which means you're probably looking at a deficit of $500 to $600 billion. To bring in health care that may cost another $100 to $200 billion on top of that, it's just going to be very, very difficult to do.
And that actually is what some lawmakers on the Hill already are beginning to put out there. They're beginning to tamp down the expectations of really how significant a change there could be.
That's right. That's right. That's why I fall back on there's a number of things that I think they can do. Incrementally, setting the foundation and also eliminating some of what I think are the big problems. This dual eligible population we talked about. Also the tax treatment. I mean, you know, if you're working for an employer that provides health care, it's entirely exempt from you from paying taxes. But another individual has to pay out of pocket because the employer doesn't. There's no equality in the tax treatment around health care. So there's a number of areas that they could clean up efficiencies or inequities that would be part of that foundation that then would allow states to move forward.
Okay. I have one final question for you. What do you think is the next big idea at the state level, looking down the road 3 or 4 years, in terms of harnessing these healthcare issues? Is there something out there that we haven't tried yet, but you're beginning to hear inklings about?
Not really. I mean, I think it is on the cost control side that I think it's a matter of how do you bring all the pieces together? How do you really, most of the work, for example, on electronic healthcare records has been at the regional level. We've had some states do a lot, but no state, for example, has really created the entire system. I mean, Minnesota and some other states are close. So I guess that would be one area where they would actually integrate the quality standards and everything into the health IT. One of the things that people don't realize in that area is that it will also lead to a lot more analysis around appropriate medical treatment, evidence-based. The data that we use now is pretty splintered. And so with electronic healthcare records, you'll be able to do a lot more analysis on effectiveness, which should lead to reduced cost over time.
Okay, thank you so much, Ray Scheppach of the National Governors Association.
Thank you.
Appreciate it.
The Kaiser Family Foundation presents health08.org, election news, analysis, and events.